That was very kind. And I think it's really to make progress in this field, we have to do a lot of collaboration. You know, I do a lot with neonatology, we do a lot with internal medicine, but anesthesia really is the key because they are the people who are our backup on labor and delivery. You all are our critical care, not only backup, but right there with us. And so we really need to be working on this together. And I think I'm going to show some of the ways that we've worked together over the last 15 years and where we can go in the future. So today we're going to review some of the current data around maternal mortality, severe maternal morbidity, but really with an eye on implementation of improvement projects. And we're going to look at some of the things we have to do to address the very significant disparities that we have in this country. And, of course, recognize the potential roles for anesthesiologists in these areas, which is the whole theme of this meeting. My only disclosures are that I am a consultant to CMS, the Joint Commission, and ARC on creating and modifying and improving new measures for severe maternal morbidity. Now, as a medical student and a resident, you're always trained to read the New England Journal of Medicine, and there's not much about obstetrics in the New England Journal of Medicine, and in fact, for many years, this was the go-to piece in my training. These were case studies published by the Massachusetts Medical Society of terrible obstetric cases in detail. And you didn't see this in OB journals. This was basically case reviews with an understanding of how to improve outcomes. And they were really trained. I don't know how many people have read this in their part of their training. They stopped this about 15 years ago, but these were formative. And they were formative in conjunction with the other leading publications that came out since 1950s through to today, which is the confidential inquiries in the UK. Confidential inquiries are published every 3 years by the Royal College of Obstetrics and Gynecology, and they review all maternal deaths in the UK. Now they've added Ireland and Scotland and Wales, and they're a treasure trove. And they've morphed over time. Now it's the UK mothers and babies reducing risk through audits and confidential inquiries, Embrace. I think the confidential inquiry is a little simpler. But the problem with the confidential inquiries, as great as they were, is they were only published as a monograph every 3 years, which limited availability. But the only place you could find that it published in a journal was in the British Journal of Anesthesiology. They came out every 3 years with a summary. And so that was go-to reading. And that led me actually to this organization, observing, as I was doing quality improvement work in obstetrics, wondering how anesthesia had done so well over time. Clearly, you all have gotten a lot of attention from medical journals, but even the Wall Street Journal, with how well anesthesia has performed in improving safety and quality over the years. And so this was a model, actually, for me. My journey actually started as a maternal fetal medicine specialist at WashU, Penn, and UCSF, but I morphed into the M in maternal fetal medicine, whereas most maternal fetal medicines are focused on ultrasound and prenatal diagnosis. I really chose to take care of the highest risk women, and that led me to quality improvement, which in turn got me into large-scale quality improvement with first the Perinatal Quality Collaborative with the very first one, and then as maternal mortality started to rise, the state asked me to develop a program that was focused on the mother in California, the CMQCC, where I've been the director for 17 years, stepped down 2 years ago. And to do that, you have to go to the source data. And I started our first maternal mortality review committee in California. California is the biggest state by far in the country. 1 out of every 8 births in the US is in California, 12%. So we have a lot of births, 500,000 a year, which means that unfortunately we have our share of maternal deaths to study and review and improve upon. So CMQCC took this data. We did these reviews with the concept that not just to categorize the deaths, but to see what quality improvement lessons we could learn from each and every one, and then to package them into quality improvement toolkits, and then do very large-scale quality improvement collaboratives, 100 hospitals, 150 hospitals at a time. And that's what it takes actually to move the needle. This led to really national efforts, and that's where I'm going to be going next, is the National Partnership for Maternal Safety, which then morphed into AIM. So I'm going to divert a moment and talk about my influences by anesthesiologists. In our initial work on maternal mortality reviews, we really stressed the importance of anesthesiologists. Sheila Cohen, who many of you may know, Grand Dame, an anesthesiologist, was one of our first co-leads, Ed Riley and now Alex Butwick. And when we started the national partnership, which became AIM, that was Jill Meyer, Barbara Scavone, and Paloma Toledo. And then at Stanford, I'm blessed with a wonderful department of anesthesiologists to collaborate with on a variety of areas. As listed here, and Brendan Carvalho and I were invited to go and work with the WHO on maternal hemorrhage. So it's been a very productive relationship all the way around. But I want to add a special call out to Brett Gucci, who was probably the leading OB anesthesiologist in Pennsylvania and Philadelphia when I was there. And just as a short story, top of my list was my last day on call as a junior attending at Penn. I struggled with an unexpected, undiagnosed placenta accreta. 25 units in a hysterectomy. We saved the woman, and she did well. But it's hard to recall a time in which placenta accretas were something that might happen once in your life. That's how much has changed in the last 40 years. For placenta accretas, every big center here has a placenta accreta center. You know, that didn't used to be the case. Melissa Bauer, also a special call out. She'll be here tonight. Her kids are actually first day of school, so that's why she's coming a little late. And I are co-PIs on a NIH grant for sepsis that is large-scale implementation in 2 states, Michigan and California. And that's been a really exciting opportunity to work together with anesthesia in 2 states. So let's talk about maternal mortality causes here. And this is a classic study led by Andrea Krianga from CDC at the time, with trends over time and trends by causes. And you can see on the left-hand side that the more obstetric or direct causes of maternal mortality have fallen some: hemorrhage, hypertension, infection, pulmonary embolism, et cetera. And on the right-hand side, you see the, quote, indirect or medical causes all rising significantly. Cardiovascular disease, incredibly so. And that's going to be our next talk. That's really a very important topic for us, which you all are even more versed in than we in obstetrics. But let me look at the center. There's very small numbers for anesthesia. When you blow those up, this is a pretty remarkable story. And again, why I've modeled a lot of what we do nationally around the Patient Safety Foundation. Anesthesia deaths, anesthesia maternal mortality deaths are illustrated here, fell from 2.5 in the late 1980s to 0.2. So I'm not here today to talk about how to give better anesthetics. That's not the issue. The issue is how we all in this room can do better for all the other causes, both on the right-hand side and the left-hand side of this curve. So maternal mortality, as May said, is high and rising in the US. This is the latest data. It doesn't show the tail on the far left. We used to be in the low teens and in the 20s, compared to other high-income countries that were in single digits. Canada, UK, many others are 6 or 7 or 8. We've been in the teens. With COVID, as to see the peak here, that hit mothers particularly hard. We're in our 30s. 35 was the peak in 2021. That's come down as COVID has moved on, partly. But it's moved on, so now we're still in the mid-20s. This is way higher than it should be. Let's look at a little bit of how maternal mortality compares to maternal morbidity. Again, this is a rough distribution of the major causes. In some data, both AFE and VTE are combined, so apologize for that. But you see, cardiac disease is well over a quarter of all the deaths in and of itself, and that how infection, hemorrhage, preeclampsia, and emboli are all roughly the same, 12 to 14% up and down, depending on the year. Thank you very much. Now, when you go to one measure of maternal morbidity, and this is, note that these maternal deaths, even though they have a high and scary rate, are really kind of infrequent, 1 to 2 per 10,000 births. When you look at ICU admissions as a measure of severe morbidity, it's 1 to 2 per 1,000, okay? More in a big center, of course. But now you see the distribution of causes changes considerably, with many more mothers admitted to the ICU are there for hemorrhage and preeclampsia than the other causes. When you look at the current CDC measures of severe maternal morbidity, which is about 1 to 2 per 100, so these are log differences, each of these steps. 1 to 2 per 100, more than half of those are related to transfusion. But now look at the distribution. This is dominated by hemorrhage and preeclampsia. 70% of severe maternal morbidity, maybe even a little higher, is hemorrhage and preeclampsia. So this is the trend line for severe maternal morbidity, CDC definition. There are other definitions out there, but the CDC definition is the most widely used. And this has been trending up. So not only do we see a rise in maternal mortality, we see a rise in severe maternal morbidity. In this case, it's driven 2/3 by increase in hemorrhage and transfusion. But even non-transfusion, all the other causes have gone up by 24% over these 6 or 8 years. So as part of our maternal mortality reviews, as I said at the beginning, we are looking very carefully at underlying cause, what's the drivers? Patient drivers, facility drivers, provider drivers. And we found a huge proportion of provider QI opportunities in 95% of the cases of hemorrhage and preeclampsia. This is actually supported with identical findings from big reviews in this state of Illinois, in two large studies there as well. And these provider opportunities can be categorized in the 3 deadly Ds, as I call them, in denial, delay, and dismissal, not listening to the patient, dismissing her fears, her concerns. So we got to remember those: denial, delay, and dismissal, and particularly as we look at disparities. These raise their head there quite a bit. So let's fast forward to the national scene. And this is an article that Barbara Scavone and I wrote in Anesthesia about the formation of a national partnership for maternal safety. That was a call for action in 2015. At the same time, we did the first national safety bundles, which was on obstetric hemorrhage. This is the beginning of AIM. And we did all these with multidisciplinary, multiple specialties, nurses, physicians, and all kinds of physicians and patients involved for each of the bundles. This morphed, the national partnership morphed into AIM, which was, in back of my mind, modeled after the Anesthesia Patient Safety Foundation, but we didn't have industry support. There's a lot of technology in anesthesia, less so in obstetrics, but we did get federal funding. Federal funding is nice when it's nice, but right now it's not so nice at the moment, shall we say. And AIM was funded by HRSA, and actually is now a line item in the federal budget called out to support. So we've made progress on that. So it was formerly known as the National Partnership, but it became AIM. So an AIM bundle is basically a checklist of items and practices on a given topic that should be adopted in every birthing site. They're short, 2 to 3 pages. They have a list of types of things you should do and some implementation ideas. So they have a 5R structure, what you need to do for readiness, recognition and response. That's what most of us think about is response, how you're going to respond to an emergency, but there's a lot of background that you have to take care of to make that action functional. And then you have to learn from it, which is the reporting and system learning, and in a context of respectful care. So there's items on all of these. We have 8 core bundles: hemorrhage, hypertension, cesarean reduction, cardiac conditions, sepsis, transition to postpartum care, mental health, and substance use. These are supplemented by what we at CMQCC call toolkits, which provide detailed background, example policies and procedures, everything you need to do real implementation. These are long, these are basically monographs, 120, 160 pages, because they're chock full of ideas and background materials. They've covered 6 of the areas as noted, but they've been widely popular. Downloaded, these are freely downloadable, and they average 10 to 14,000 downloads. Open source at cmqcc.org. We have a new one on maternal sepsis, an upgrade, major upgrade that Dr. Bauer and I have led. That is actually going to have a release webinar day after tomorrow when I go back to California. And everyone is welcome to join. So far we have over 900 registrants to the webinar. So AIM itself is now in all states except Wyoming, which only has 6,000 births, doesn't even have a medical school or a tertiary center. But it's made significant inroads at various levels, I'd have to say, but it has a presence. The hemorrhage and hypertension bundles are the ones most widely used, but I'd like to point out that it's not just doing the right thing, but in obstetrics and probably in anesthesia, timeliness is critical. In hemorrhage, every 5-minute delay before a second uterotonic can result in a 31% higher rate of hypotension. 10-minute delay in anesthesiologist involvement. This is one of my favorites. If you don't call the anesthesiologist to the bedside in a timely way, that increases the severity by an odds ratio of 1.6. Okay. Essential previa, as you all have, many of you have seen, can lose the woman's entire blood volume in 14 minutes if it's wide open. Hypertension, there's a big effort nationally to treat severe range systolic blood pressure within 60 minutes. It should be 30 minutes, but that's what we settled on as a national target. It's actually going to become most likely a Joint Commission performance measure in the next year. So that's something that you all will be paying attention to as you work with mothers getting regional anesthetics and saying, do I treat, do I not treat? You need to treat. Sepsis, it's, as you know, in non-obstetric settings as well, you've got to get the antibiotics and the fluids in as quickly as possible. So how do you push implementation? And no one likes to change just because they want a new set of clothes. People need to have some incentives to actually change their practices. So we've gone to the big boys, if you would. Big boys are the people who do accreditation, the people who pay, i.e., and those are ones we've gotten involved. For the Joint Commission, accredits 85% of the hospitals in the country, and they have taken the AIM bundles for hemorrhage and hypertension and rewrote them in Joint Commission language. It's a translation, literal translation, of the bundles into standards. Standards is a tough word. Standards is what a Joint Commission assessor, surveyor will look at when they come to visit your facility. And so instead of the surveyor coming to my unit as chief of OB and saying, can I see your crash cart? Which has no meaning in OB, but that's what they used to know how to do. They may have looked in the ORs to see if the standards were the same as the general ORs as well, but nothing really to do with obstetrics. But now they are given the tools to look at how you handle hemorrhage and how you handle preeclampsia, and are you following the national bundles. So this is a big step. The second big step was for CMS to decide that severe maternal morbidity was a national outcome measure and should be reported at the hospital level. CDC uses it as a population health measure, but now CMS with the Joint Commission have turned this into a hospital measure with key caveats, with key changes, such that it is risk adjusted. Conditions that were indicators for severe maternal morbidity that were present on admission are not counted for the hospital. And it can use additional data besides ICD codes, such as labs and some vital signs on admission, and the risk adjustment algorithms. So this is a step forward. It is now, though, required, mandatory for every hospital in the country with 2024 data. So this is happening. It still needs some refinement. Some hospitals are having some trouble with SNOMED codes and some of the other new things. But this is actually going to be part of the birthing friendly initiative that CMS has rolled out. That's going to include the low-risk first birth C-section rate, the severe obstetric complications, which is their name for severe maternal morbidity, as well as adoption of national safety bundles. So that's in the mix as well. So have we moved the dial? May mentioned that we have lowered the maternal mortality rate in California quite significantly. I didn't choose to show that slide today. It's pretty dramatic, though. But we have, because we wanted to focus on severe maternal morbidity. And there's a study from California and a study from Texas showing that you can significantly reduce, or this second study is from Illinois, actually, that just came out a few months ago, showing that you can reduce severe maternal morbidity from hemorrhage and hypertension using large-scale quality improvement projects. However, we've done less well with some of our population, and particularly persons of color. On the right-hand side of this is in-hospital deaths per 100,000 for Black, Hispanic, Asian Pacific Islander, and white at the bottom. And one of the national disgraces is that Black women have 3.5 to 4 times, depending on which specific measure you use, higher rates of maternal mortality than white. There isn't any other measure I can think of that's anywhere near that. disparity, 3 to 4 times higher. And that's held true, as you can see, in 2 different time periods. It is nice that this is in-hospital mortality, as opposed to the more general maternal mortality, which includes out-of-hospital, of course. And we're going to talk about that particular cardiovascular disease in the next talk. But this is showing that it has reduced some in this time period, which is encouraging for what we have been doing in the hospital for acute care that we all think that we're addressing the issue for. On the left-hand side is severe maternal morbidity, and that's been rising. The blue is the most recent time period, and that also has a major disparity. It's a little more than 2 times higher in Black birthing persons and about 40% higher in Hispanic. Some of this is related to comorbidities, but comorbidities isn't a reason for us not to strive harder. Okay. So when we've done large-scale quality improvement projects on trying to address disparities, we have mixed results. Most quality improvement projects do much better looking at process measures than they do at outcome measures. Outcome measures are notably harder. So in this case, the process measure on the right-hand side was to treat women with severe blood pressure in a timely way. And they were able to show that, a couple studies have shown this as well, at single hospitals. They can show that they are now treating everyone the same, but that doesn't mean they had the same outcomes just from that, improving that one process measure. When we did that on the left-hand side here in California, looking at hemorrhage rates, we could show significant reduction in morbidity in Black birthing persons or Black mothers by our participation in our hospitals that participated in our collaboratives. But there was still a residual, and the residual actually was interesting because it was largely related to higher rates of anemia and much higher rates of C-section in Black mothers. And so these can be complex, the drivers, as pointed out. So I'm going to, as I approach the end, I'm going to be talking about the key principles that we've had identified. I talked about the 3 deadly Ds before. Now we're going to have a bunch of Ts. Teamwork is obvious. We have to be working together. We need tools or toolkits, direction and timeliness. And I'm going to add trust to this. And trust, i.e. Getting rid of dismissal, is a really key issue that we're also going to be talking about later in this meeting. Many persons of color do not trust us. And it's hard to provide appropriate care in that setting. And if patients are disrespected, they're not going to come back. They're not going to do what we ask of them. And so our challenge is, as an anesthesiologist or as a hospitalist OB, is how you develop trust in 5 minutes or less. So I think we all can develop our own strategies, but that's a conscious thing you have to be working on. How do you develop trust in under 5 minutes? And a lot of it is about sitting down and asking what their goals are, what they want out of this opportunity. So with that in mind, we've really taken a direction of how we can improve communications with our patients, make them aware of what's going on, starting with an urgent maternal warning signs, which is now in 90 languages. It has drill down on it, which is very, very exciting. It's modeled after the CDC Hear Her campaign. It's available for free from the ACOG AIM site. We are putting this up throughout our labor and delivery units, in triage, in labor rooms, in prenatal office walls, as well as putting it, we've developed ways of putting it on the phone. So the patient and her partner can see the the urgent warning signs in their own language. As part of our sepsis grant, we, with a community engaged group, we developed advocacy tips for patients in English and Spanish, and also it's one thing to have urgent warning signs, it's the other thing to have the patient listened to by the triage nurse or the triage staff. So we've been working on that with warning signs follow-up. So I'm going to leave you on the second to last slide with an expanded view of maternal deaths. This is a classic circle, circle, circle slide, whereas the traditional definition of maternal mortality, which is 42 days and related, is the small one at the bottom. Pregnancy-related mortality, which goes out to a year, encompasses about a third of all deaths that happen to a pregnant person within a year of delivery. The rest are pregnancy-associated deaths, which we didn't use to count. So cardiovascular disease is the big driver in this period after delivery, but within a year. But as we look at that time period, that very large group of patients in that time period, up to a year, that is pregnancy-associated, maybe not related to substance use, suicide, and trauma. Those are the big ones out there that are now being eyed to being counted. So I'm going to end with a statement from your society, the American Society of Anesthesiologists, in October of 2022, as to what your role is on reducing maternal mortality and severe maternal morbidity. The top 5 of these above the line are high-level or state or national actions. We've been talking about these already. The other 4 are hospital-level activities. And I'm hoping that when we're done here on Thursday, we can add a lot more to that list. Because I think we have a last mile issue. We know what to do in the big scale. We know nationally, we have bundles, we have toolkits, et cetera. But it's that last mile that we really need to be working on. What happens at the bedside? How can we move beyond the bedside, actually, for some of these causes? So we're looking at below-the-line activities. So thank you very much, and I look forward to the meeting.